on talking about the outpatient and the surgical setting. And the reason for that is that I would like us to be able to discuss and consider antimicrobial stewardship in the context of COVID, as I think that's absolutely critical now. So just to get started, I just really want to convey this idea that stewardship, to me and to most of us, is not just the issue about addressing excessive use, but also ensuring equity and access, not just access to the agents themselves, but access to effective therapy, and optimizing and preserving the use of our existing resources, and indeed are up and coming, although I must say I'm not too optimistic about them in spite of what Luke has just been telling us. But we're going to need to be able to preserve their effectiveness when we actually can use them. And increasingly, stewardship must address the issue of using our agents better and more creatively, linking with diagnostics to really optimize how we can treat key, tricky, resistant infections. So, what's happening with global consumption of antimicrobials? Well, it's just getting worse and worse. So this is data that goes up until 2015, which seems, of course, ages ago now. However, this was a paper that was published in 2018. And I think it's really interesting because if you look at that first line graph, you can see this increase in upper and middle income and in low middle income countries. So that's per individual. So that's the individual basis. But if you look to the bar chart, my goodness me, and you look at the total consumption, it has been an amazing increase in usage in India and China, for instance. Absolutely incredible. And some of this, of course, because of the population density in these low middle income countries, that gets hidden when you look at it per individual, but the increase is absolutely staggering. So it's not just low and middle income countries. There's, of course, a massive problem in Europe. And this is a really elegant paper by Alessandro Cassini that for the first time looked at the impact of antimicrobial resistance, not just in the laboratory, not just in the Petri dish, not just in magnificent testing instruments, but actually in what does it mean for patient populations? And what does it mean in terms of disability adjusted life years? Well, it's really quite extraordinary. So 170 disability adjusted life years per 100,000 population, similar to the combined burden of influenza, TB, and HIV, quite extraordinary. And that 75% of this clinical burden is due to that which is taking place related to healthcare. Absolutely shocking. So we've got a way to go here. And it's really beautifully presented. It's a very nice paper, well worth looking at. And here it is broken down by the types of resistance patterns. And you can see in green carbapenem resistance and colistin resistance. And you can see at the top of the league table is Italy and then Greece and Romania. Anyway, really nice paper. It's not just a low middle income country problem, and it really is a clinical and public health burden. In terms of what we can do about spread, we also need to think about the impact of exposing organisms to antibiotics in terms of weaponizing them and generating small clonal outbreaks that then disseminate. And this is beautiful work from colleagues David Alison, Howard Grundmann et al. That came out in 2019, emphasizing how just small clonal outbreaks can rapidly disseminate and how absolutely critical it is to have a major and sustained focus on improving infection prevention and antimicrobial stewardship to prevent this clonal spread of resistant organisms. And in this case, this was beautiful molecular epidemiology around Kleb pneumo. So I'm now going to talk a little bit about advances in our approaches to antimicrobial stewardship. First, I just want to touch on some non-technological ones. And I want to highlight the importance of us actually being able to monitor and look at this. This is really important, that we have the capacity in the systems to actually look at what we're doing and the impact. We need data linkage and surveillance systems that will enable us to do this, ones that are pragmatic and realistic and use what we already have. We need to be able to do this to make sure that we don't do anything too mad, and that stewardship interventions are safe, effective, and don't compromise access to effective therapy. So it's really important we do that, and that we get the message out and be able to demonstrate that interventions are safe. There's more and more emphasis on using the AWARE index that you're probably all familiar with, which is about the WHO classification of antimicrobials according to whether they should be access ones, watch ones, or reserve ones. It's a very, very useful way of looking at how we use antimicrobials beyond looking at the individual agent. And indeed, in the UK, it's in our NHS hospitals, we have to report against how we are faring against this AWARE index. And lastly, in terms of advances in stewardship approaches, I want to emphasize how it's becoming more and more recognized, the role of social sciences, behavior change, organizational and behavioral approaches, absolutely critical, and we need to work closely with our colleagues who are experts in this field. So I just want to flag a freebie. This is something available online, which is led by Rahila Ahmad, which is about how you can look at organizational structures to embed antimicrobial stewardship within institutes and organizations. So it's a BSAC output that is free for everybody. I also wanted to flag work that's been led by our colleague that you've met before, Asmita Chirani, and other colleagues on a massive online learning course on the application of social sciences to stewardship, which is available all around the world. But now I'm going to switch from the non-technological to the technological advances and some of the innovation exists that we can apply to stewardship. I'm only going to touch briefly on these because I don't have time, but I just think we need to be aware of the advances that are within our reach, and also how important they are to link to our diagnostics, as Luke was saying before. So we can do much more in terms of decision support to help with decision making, and indeed this is beautiful work that Luke initiated. It's also really important that we actually understand how decisions are made, so that we don't have technology that doesn't actually match with the real world, so that we really need to work with the end users, which has been a critical part of this. We need to be able to harness our artificial intelligence. I mean, my goodness, it's being used for absolutely everything else. We should be embracing it and using it creatively and safely within the realm of antimicrobial stewardship. So this is already there and is really really taking on quite a pace. And of course, the ethics and the behaviors around the use of data and how it's used is really important. It must be done safely and in a supervised way. So it's not just enough that we can pick our drug, say it matches this bug, this resistance profile, this genetic profile. We can also do much more about targeting the combination, dosing, really, really personalizing the prescribing. And can I just remind everybody out there, sometimes people are on drugs that aren't antimicrobials. Just want to put it out there. Remember, there are other diseases, apart from infectious diseases, hard for us sometimes, but it is really important that we acknowledge that people may be on other drugs that interact, and we have to work in that sphere and recognize it. Personalizing doses and personalizing drugs according to comorbidities and to polypharmacy. And decision support can certainly help with that, but there's also technology in terms of point of care monitoring, biosensors and diagnostics, and also direct connectivity and closed loop control, similar to what is used in insulin control and diabetes. So if we can link all of this together, real-time monitoring, in vivo pharmacodynamics, closed loop control, integrated with decision-making, so that's kind of stewardship paradise. But it is real. We are getting there. We are doing work with microneedles and biosensors that is not just you know, cloud cuckoo land. This has now been used in humans and volunteers, and it's going to be tested in the outpatient and the OPAT in environment. And as I said, the issue about linking it like insulin to diabetic control pumps is already there and already proven. Now, I'm going to shift gear entirely because I think it's critical that we talk about antimicrobial stewardship in the context of COVID. So when I was asked to talk at this conference before, it was, oh, will we be flying to Jordan? What will be happening? And, you know, we've all been through a lot. We're working really, really hard. And we need to reflect on what does antimicrobial stewardship now mean in the world in the context of COVID? What's the concern? What are the broader implications? And what is the emerging evidence from research? To begin with, there wasn't enough research, but now there's too much and a lot of it is rubbish. And how can we navigate through this? And how can we sustain this momentum around antimicrobial stewardship? There was a lot of press around antibiotics being overused and, you know, it's all absolutely terrible. But it's far, far more complex than that. And I'd like to take a few moments to discuss this complexity and what it actually means. So we can't just bash doctors over the head for using too many antibiotics and it's going to drive everything that's truly dreadful. We need to think really carefully of this. And I'll just go through some of the implications. And I think some of the very simplistic responses are really not adequate. So what is the potential impact on antimicrobial resistance? Well, we don't know yet. We don't know yet, and we need to set things up so we actually really learn and mitigate the potential poor impact, but we also need to be able to harness what's good. So here we've listed some positive factors, negative factors. Actually, fantastic. People think that infection control matters. Hooray, fantastic. Everybody now realizes that actually infection control, interrupting transmission is pretty important. So really, really useful. The role of social distancing, potentially the avoidance of unnecessary contact with healthcare, all may influence and have an impact on reducing AMR. But in contrast to that, there are all the problems with overuse in acute healthcare and ways that our healthcare has been disrupted that may have interrupted how we use them, and also the difficulties in diagnostics and distinguishing between bacterial infection and COVID when it presents. So I'll talk a little bit more about these. So challenges within our hospitals. Now, the absolutely overwhelming high burden of acute cases, well, that was one. The challenges to differentiate from acute bacterial infection, the high rates of use in acute care, possibly high rates in ITU, not just of bacterial, but fungal infection, and the massive disruption in healthcare. But we still don't know how this yet is impacting on AMR in the long term, and how can we make sure that people are getting the right therapy when they need it. This is some really rough, raw data that I'm sharing with you. This is just our local stuff in terms of what was going on in our ITUs in the peak of COVID. So you can see that we had a little blip of candidates. The number, sorry, the y-axes are all different scales, so just kind of ignore that. It was great to see our E. coli bacteremias went away. Yeah, fantastic. We want to say that was all our good work. Of course it wasn't. It was because we weren't seeing all our normal patients and oncology, etc., and blood cultures weren't being taken as much. But even although blood cultures weren't being taken quite as much, look at that last peak, which is in contaminants. So when they were taken, people wearing PPE, etc., we had a problem with that. So it's really interesting. And also we're seeing outbreaks of some very unusual resistant organisms in the aftermath and tail end. Sorry, not tail end, far, far too optimistic. Oh, dear, dear. Okay, and then also local trends in antimicrobial use. So you can see that we had, so there's a big peak there, a near doubling of our antimicrobial use in ITUs at the peak of COVID, but that has settled down. And I also want to flag the truly extraordinary work of our pharmacists. So not only dealing with the complexities of this, but also drug shortages at the same time. Anyway, So we decided to actually look at what was going on in the world, and this was work led by a younger colleague of ours, Tim Rawson, who works with Luke and myself, who led this review. It came out in CID. It came out in May, and this was highlighting the mismatch between the reported co-infections, around 8%, and the massive antimicrobial use that was seen, so 72%. And often broad spectrum in nature, and the evil quinolones, of course, featured there, as well as massive use of carbapenems. But the difficulty in a lot of these papers was that nobody discriminated between normal acute care and level 3 ICU care. So it's really difficult to untangle what this actually means. Microbiology, very poorly reported. Secondary infection and critical care seems to be a much higher risk. And ventilator-associated pneumonia, really, really important, but nobody reporting on the day's, duration of ventilation. So it's complicated, and we need to report this better if we are to understand it. So since this review that came out in May, we've looked at other papers that have come out, and it's been the same type of story. Most studies do not provide any standardized investigation for reporting, and they don't differentiate adequately between presentation at acute care and in critical care. And the site of co-infection and the role of the risk of standard healthcare associated infection, particularly in ICU, has still not been teased out adequately. And I think this is important, that we should do better. There's been a couple of other papers. There's been a large study in Spain and Barcelona, which essentially reinforces what we said before. And there's a very nice paper that's out from Luke and his colleagues at Chelsea and Westminster, which also supports these findings and also demonstrated the rise in contaminants seen in blood cultures. And the other important point is that the organisms that are being seen are not unusual organisms. They are the organisms that you would normally see in your community-acquired infections and in your healthcare-associated infections. They match the normal local epidemiology. And it's really important that we get this nuance of what is going on in COVID, co-infection, and antimicrobial use. As I said, we need to understand what are the risk factors. Is the co-infection attributable to COVID? Is it co-occurring, or is it a secondary infection? And we also need to understand and report this in a standard way. And I'm really pushing for a better framework for us to do this and to learn. So shortly after our initial review, WHO came out with these guidelines, and as you can see, they were not recommending empiric antimicrobial therapy for initial presentation unless it was severe infection. And then all the other advice is standard practice in antimicrobial stewardship in terms of reviewing, short duration as possible, blah, blah, blah. And also that antimicrobial stewardship teams should be maintained throughout COVID. So a little bit more about critical care co-infections. There's been more and more published on this. And we need to really understand the role of prolonged ventilation. And of course, now the increasing role and the use of steroids contributing to secondary infections in ICU, and fungal infections in the ICU associated with steroid use. And it's, as I say, really important that we get to a standardized way of looking at these. So I just want to emphasize that how complicated this is. So there's so much around, it's all going to be about AMR, but it's not that simple. And we need to do better at understanding this and work together to understand our own data. We also need to understand that because we work in critical care and in acute care, actually, what is happening in the community? And that's where most of the antimicrobials are being used at a population level. So we really need to understand not just acute care, not just critical care, but the whole lot. We really need to also remember we need to think about the non-COVID patients. So how are we going to protect and look after, and what is the impact on non-COVID patients? We need to think about how this links to other critical aspects of delivering antimicrobial stewardship, such as immunization programs and the management of TB. There are many consequences that could fuel AMR, but there are also some that could potentially reduce it if we could play our cards right and understand and harness those and work on those and sustain those. And research is needed at multiple levels. So it's going to be complex. The impact's going to be huge and long-term. We need to coordinate our strategies. We need to coordinate our strategies for research and to inform policies and interventions. And we need to really begin to understand what the long-term impacts might be, both to AMR, but also to the access to effective therapy. And going back to the title, I just want to say that stewardship will remain inevitable, and it will remain an increasingly critical global challenge in the context of COVID.